Chapter 8: Epidemiology and Population Health. Epidemiology is the study of the distribution, determinants, and dynamics of health and disease in groups of people in relation to their environment and ways of living. This chapter reviews epidemiologic measures of the overall health of groups of people, followed by measures of risk and the epidemiologic approach to the episodes of disease. Epidemiology and overall health. General epidemiological descriptors of the overall health of groups, and especially of entire populations, include population pyramids, mortality, life expectancy, and infant mortality, among other measures. These are commonly used to compare the health of populations in different areas or different countries. Population pyramids. The age structure of a population has profound effects on present and future public health and is of great interest to health planners. Population pyramids are histograms showing the percentage of a population that falls in different age groups, typically 5-year cohorts. But unlike a conventional histogram, they are turned on their side, and male and female data are shown on opposite sides of the vertical axis. They may resemble a pyramid in the case of population of a developing country with a large number of births, a fairly high infant mortality rate, and a relatively low life expectancy, as shown for the case of Angola in Figure 8.1. However, highly developed countries such as Japan and United States, with lower birth rates, low infant mortality, and a high life expectancy, produce a different pyramid as shown in Figure 8.2. Figure 8.2 is a constrictive histogram illustrating an aging population. It portends future problems for healthcare financing when an aging population with increasing needs for medical services becomes dependent on the productivity of a progressively shrinking proportion of the population who are of working age. The ratio of the productive population, nominally 20 to 64 years old, to the non-working population under 20 and above 64 years old is called the dependency ratio. Dependency ratio can be calculated by population less than 20 years old plus the population greater than 64 years old divided by the population between 20 and 65 years old multiplied by 100. Similarly, youth dependency ratio is the ratio of the under 20s to the 20 to 64 years old, and the old age dependency ratio is the ratio of the over 64s to the 20 to 64 years old. The population pyramids illustrate that the old age dependency ratio in Japan is very different from that of Angola. Here we have an example of a histogram showing the population's ages and how many are there in millions. And as we see that a lot are born, but very few survive to a high age. So we can say it's probably a developing country, receding health. Whereas here we look at Japan. Isn't that interesting? Look at that. You have less amount of births, but they tend to survive longer. So the population has more prevalence, I suppose. And you see that most of them tend to survive in a higher ages. Measures of life expectancy. Life expectancy is the average number of years of life that a person is expected to live. It is derived from a life table analysis, which was discussed in Chapter 4. Among cohorts of people who have already died, such as people born before 1890, life expectancy figures are as accurate as the raw data they are based on. For people currently living, they are based on projections, usually with the assumption that current mortality rates remain unchanged. Possible future advances in medicine or broader socioeconomic changes produce uncertainty in these projections. Life expectancy at birth is likely to be quite unrepresentative of the life expectancy of adults, especially in developing countries or in historical cohorts, where a high infant mortality rate results in a very skewed distribution of ages at death. In such situations, life expectancy at, say, 5 years of age may be dramatically higher than life expectancy at birth. As a result, age specific life expectancies are likely to be much more informative. Life expectancies can also be estimated for men versus women, smokers versus non smokers, different races, and so on. These estimates are of particular interest for health planners and life insurance companies. The impact of premature death can be described in terms of years of potential life lost. YPPL, also called years of life lost or YLL. For example, in a population in which a 40-year-old has an average life expectancy of 70, death at the age of 40 would result in 30 years of potential life lost. This figure reflects the effects of changes, whether socioeconomic in medical care or public health, according to the ages of the people that they affect. Providing defibrillators in nursing homes, for example, is likely to produce a smaller reduction in years of potential life lost than is providing defibrillators at sporting venues, all other things remaining equal. Other measures introduce consideration of the quality as well as quantity of life expected. A disease such as osteoarthritis, which is not fatal in itself, may produce literal no years of potential life lost, but it may produce significant and prolonged disability, which is described by disability adjusted life years, or DALYs. Disability adjusted life years are calculated as the sum of years of potential life lost plus years left with the disability. As such, one disability adjusted life years reflects the loss of 1 year of expected healthy life, such as from disease. And disability adjusted life years are therefore the converse of quality adjusted life years, discussed in Chapter 7, which reflect a gain of years of life, such as from a treatment. Life expectancy figures can be refined by considering a quality of life and the effects of disability to produce health adjusted life expectancy, which is obtained by subtracting years of ill health, weighted like QALYs according to severity, from standard of life expectancy. Like life expectancy, health adjusted life expectancy can also be calculated for people of different ages. Osteoarthritis, again, may not affect life expectancy, but may have a major effect on health adjusted life expectancy. Measures of disease frequency. Many of the epidemiological terms that follow are rates, which all consist of a numerator, usually the number of people with a particular condition, and a denominator, usually the number of people at risk. And they usually specify a unit of time. Mortality. Mortality is a number of deaths. The mortality rate is the ratio of the number of people dying, whether of all causes or of a specific disease, to the total number of people at risk. Mortality rate is equal to the total number of deaths divided by the total number of people at risk of dying per unit of time. Mortality rates may be expressed as a percentage, or as the number of deaths per thousand, or 100,000 people, typically per annum. Infant mortality is the number of deaths of infants under 1 year of age. The infant mortality rate is the ratio of this to the number of live births, usually expressed per thousand live births per annum. So, infant mortality rate is equal to the total number of deaths under 1 year of age divided by total number of live births per annum. Similarly, under 5 mortality rate is the number of deaths of children between birth and 5 years of age per thousand live births per annum. The case fatality rate is the ratio of the number of people dying in a particular episode of a disease to the total number of episodes of the disease expressed as a percentage. So, case fatality rate is equal to the number of people dying in an episode of the disease divided by the total number of episodes of the disease times 100. The case fatality rate is a measure of the prognosis in terms of life or death of an episode of a disease because it shows the likelihood that one episode of it will result in health. It is used to follow the effectiveness of treatments over time or in different places, such as case fatality rate of acute myocardial infarction or pulmonary embolism this year compared to 20 years ago, or in a hospital A versus hospital B. Adjustment of rates. Mortality rates are commonly compared across different populations. However, if the populations have different age structures, comparisons will be biased. Alaska's mortality rate in 2008 was 507.5 per 100,000 of the population. Florida's was 931.2. Can we conclude that living in Alaska is conducive to longevity? No, Alaska has a much younger population than Florida, so Alaskans would clearly be less likely to die in any given year. Other things remain equal. The mortality rate alone, therefore, tells us nothing about the real underlying difference in the rate of death between the states. This biasing influence of a confounding variable such as age can be removed by the technique of adjustment or standardization of rates. This involves calculating rates for the two populations as if they were both the same in terms of the confounding variable, in this case, age, often by applying the rates to a standardized population, such as to the age structure of US population as a whole. This kind of process of adjustment can be done not only for age, but also for any other relevant factor that differs between two populations that are being compared. Alaska's 2008 age adjusted or age standardized mortality rate was 739.6 per 100,000. Florida's was 679.0. It seems that when age is taken into considerations, Floridans are actually less likely to die in any given year, contradicting the impression given by the crude unadjusted mortality rate by the US Department of Health and Human Services in 2011. Comparing adjusted mortality comparing adjusted mortality rates in a given community with the mortality rate in the population as a whole gives us an idea of whether the rate of death, either overall or from a particular disease, is truly higher in that community. This ratio of actual to expected deaths adjusted by age and gender is the standardized mortality ratio or SMR. As standard and an SMR of 1 means that the actual rate of deaths is the same as the expected rate. For example, if the standardized mortality ratio for motor vehicle accidents in Florida was 1.5, this tells us that the rate of death from these accidents in Florida is 1.5 times the expected rate in the United States as a whole. Even after taking Florida's age and gender structure into account, which would lead us to ask what other factors could account for this difference. Incidence. The incidence of a disease is a number of new cases occurring in a particular time period, such as a year. The incidence rate is therefore the rate of new cases of the disease to the total number of people at risk. Here we have an example of incident rate, which is equal to the number of new cases of the disease per divided by the total number of people at risk per unit of time. The incidence rate is often stated per 100,000 of a population at risk, or as a percentage. Incident rates are found by the use of cohort studies, which are therefore sometimes also known as incidence studies, as discussed in Chapter 5. For example, if the incidence of shingles in a community is 2,000 per 100,000 per annum, this tells us that in 1 year, 2% of the population experiences an episode of shingles. Note that mortality is actually a special form of incidence, in which the event in question is death rather than contracting a disease. In a disease that is always fatal, mortality and incidence will ultimately be the same. Mortality figures are likely to be more accurate than incidence figures because deaths are always recorded, while episodes of illness are not. Prevalence. The prevalence of a disease is the number of people affected by it at a particular moment in time. The prevalence rate is therefore the ratio of the number of people with the disease to the total number of people at risk, which is usually taken into the total population, which is usually taken to be the total population. So, prevalence rate can be calculated by taking the number of new cases of the disease and dividing it by the total number of people in the population at any particular time. Like incidence rates, prevalence rates are often stated per 100,000 people or as a percentage. They're generally found by prevalence surveys. For example, at a given time, 80 out of 100,000 people in a given community might be suffering from shingles, given a prevalence rate of 0.08%. Prevalence is an appropriate measure of the burden of a relatively stable chronic condition such as hypertension or diabetes. However, it is not generally appropriate for acute illnesses as it depends on the average duration of the disease. It is of little value to speak of the prevalence of pulmonary emboli or myocardial infarctions. Prevalence is equal to the incidence multiplied by the average duration of the disease. So, an increased prevalence rate may merely reflect increased duration of an acute illness rather than suggesting that members of the population are at greater risk of contracting the disease. The incidence and prevalence rates of shingles given in the above example suggest that the average episode of this illness lasts about 2 weeks, as the prevalence is 1/25th of the annual incidence. If a new treatment cut the duration of an episode of shingles in half to about 1 week, meaning 1 out of 50th of a year, it did nothing to prevent shingles from occurring. The incidence would not change, but the prevalence at any given time would be cut in half. Before a new treatment is given, for instance, here's an example, the prevalence would be annual incidence times average duration in years. So in this example, it would be 2% of times 1 divided by 25, yielding 0.08%. But suppose you give a new treatment, and in that case, you are multiplying 2% by 1 over 50, which will decrease the prevalence of that disease to be 0.04%. Incidence and prevalence are both measures of morbidity or the rate of illness. An epidemic is the occurrence of the number of cases of a disease that is in excess of normal expectancy. Although it is typically applied to infectious diseases such as influenza epidemic, it can be applied to any kind of disease such as an epidemic of obesity. A pandemic is an epidemic that affects a wide geographic area. The term epidemic is used to describe a disease that is habitually present at a given geographic area, while hyperendemic refers to persistent high levels of a disease. So, what is an epidemiologist's bathtub? What are they always dealing with? Here we go. The relationships between incidence, prevalence, and mortality in any given disease can be visualized with the aid of the epidemiologist bathtub shown in figure A3. The flow of water through the faucet into the bathtub is analogous to incidence, representing the occurrence of new cases of the disease in the population at risk. The level of water in the tub represents the prevalence of the number of cases of the disease existing at any given point in time. The flow of river out through the drain represents mortality. The evaporation of water represents recovery, whether spontaneous or through treatment, or the emigration of people with the disease so that they are no longer part of the population in question. Alzheimer's disease provides an example of the application of the bathtub. If the incidence in flow of water of Alzheimer's disease is roughly constant, and modern medicine is able to keep Alzheimer's patients alive for longer, the rate of mortality from disease will be reduced, partially blocking the drain. However, because there is no cure for the disease and recovery never occurs, the result is clearly an increase in the water level, which is apparent in the United States today. This picture is also broadly true for HIV and many other chronic diseases in the United States. Measurement of risk. Thing we need to know about this is that information about the risk of contracting a disease is of great value. The knowledge that something is a risk factor for a disease can be used to help in preventing that disease, to predict its future incidence and prevalence, to diagnose that disease. Diagnostic suspicions are higher if it is known that the patient was exposed to a risk factor, for instance. And it is also important to establish the cause of a disease of unknown etiology. So, let's talk about ab- different types of risks. Absolute risk. The fundamental measure of risk is incidence. The incidence of a disease is, in fact, the absolute risk of contracting it. For example, if the incidence of a disease in 10 per thousand people per annum, then the absolute risk of a person actually contracting it is also 10 per thousand per annum, or 1% per annum. It is useful to go beyond absolute risk and to complete the incidence of a disease in different groups of people to find out if exposure to a suspected risk factor, such as smoking cigarettes, increases the risk of contracting a certain disease, such as lung cancer. A number of different comparisons of risk can be made, including relative risk, attributable risk, and the odds ratio. All these are called measures of effect. They measure the effect of being exposed to a risk factor on the risk of contracting a disease. The ideal way of determining the effect of a risk factor is by a controlled experiment, but as this is rarely ethical, the best alternative is the cohort prospective study, in which the incidence of a disease in exposed and non exposed people can be observed directly. One of the main goals of these studies, such as the Framingham studies described briefly in Chapter 5, is to find the extent to which the risk of contracting the disease is increased by exposure to the risk factor. The two measures that show this are relative risk and attributable risk. So let's talk about the relative risk. What we need to know about relative risk is, well, relative risk states by how many times exposure to the risk factor increases the risk of contracting a disease. It is therefore the ratio of the incidence of of the disease among exposed person to the incidence of the disease among unexposed person. So here we have the formula of relative risk, where we see that the incidence of the disease among persons exposed to the risk factor divided by the incidence of the disease among persons not exposed to the risk factor. For example, Table 8.1 reports the results of a hypothetical cohort study of lung cancer, in which 1,008 heavy smokers and 1,700 non smokers in a certain city were followed by a number of years, for a number of years. The incidence of lung cancer over total time period of the study among people exposed to risk factor cigarette smoking is 183 divided by 1,008, or approximately 18%, while the incidence among those not exposed is 12 divided by 1,074, or approximately 1%. The relative risk, therefore, is 18% divided by 1%, or 18, showing that people who smoked cigarettes heavily were 18 times more likely to contract lung cancer than were non smokers. Note that this is not a measure of absolute risk. It does not tell us the likelihood of heavy smokers contracting cancer in absolute terms. Because relative risk is a ratio of risks, it is sometimes called risk ratio or morbidity ratio. In the case of outcomes involving death rather than just disease, it may also be called the mortality ratio. Reports of risk reductions due to treatments in many clinical trials and in almost all pharmaceutical advertisements are of relative risk reductions. Relative risk reduction is equal to 1 minus relative risk. Relative risk reduction figures may be misleading if not understood properly. This can be illustrated by the well-known West of Scotland coronary prevention study done by Shepherd et al. In 1995. This study was actually a double-blind randomized clinical trial in which over 6,000 men with elevated cholesterol were randomly assigned to take either a placebo or the cholesterol-lowering drug, pravastatin, for an average of 4.9 years. And as a result, what we saw was that there were about 73 deaths from cardiovascular causes in the placebo group. That's about 3,293 men gone. The cardiovascular mortality rate was therefore 73 divided by 3,293. Oh, I'm sorry. That's how many men were tested. Okay. So that resulted in about 2.2% of a mortality rate or relative risk in this group. In the pravastatin group of 3,302 men, there were about 50 cardiovascular deaths, giving a mortality rate of 50 divided by 3,302, or 1.5% risk. So a lot less risk with that drug. So the relative risk of death in those given the drug is then 1.5 divided by 2.2, which is equal to 0.68. So the relative risk reduction is 1 minus 0.68, which is equal to 32%, showing that an impressive 32% of cardiovascular deaths were prevented by the drug. Good show. However, the absolute risk reduction, ARR, is the difference in absolute risk rates between the placebo and the drug. That is 2.2 minus 1.5, yielding 0.7%, a far less impressive sounding figure, showing that of all men given the drug for 4.9 years, 0.7% of them were saved from a cardiovascular death. Yeah, that doesn't sound very nice. So absolute risk reduction allows calculation of another statistic of clinical importance, the number needed to treat, or NNT. If 0.7% of patients' lives were saved by the drug, this implies that 100 divided by 0.7 is equal to 143 patients. 143 patients would need to be treated to save one life. The formula for number needed to treat is therefore equal to 100 divided by absolute risk reduction. Looking at number needed to treat may allow the effectiveness of different treatments to be compared. The number needed to treat allows a further calculation, the cost of saving one life with the treatment. So in the previous study of West of Scotland coronary prevention study, it kind of showed that 143 men needed to be treated for 4.9 years, about 58 months, to save one life. At that time the study was done, the drug cost approximately $100 per month in the United States. Ouch. So it would have cost 100 times 58, which is 5,800 to treat one man for this length of time in medication costs. It would therefore cost 5,800 times 143 or $829,400 to prevent one cardiovascular death over this period. Not too good. Well, by 2011, however, the drug cost less than $4 a month. So it would have cost 4 times 48 times 143, about 33,176 to prevent one death. That's more palatable. These figures give a very different perspective on the value and cost effectiveness of a treatment than simply saying that it reduces the risk of death by 32%. Similar analysis can be performed easily for almost any clinical trial in the literature. Related to number needed to treat is the concept of the number needed to harm. For example, in that study that we were talking about, elevations in creatinine kinase greater than 10 times the upper limit of normal were seen in 4 of the 3,302 men who took the drug, but in only 1 of the 3,292 men who took the placebo. The absolute risk increase of elevated creatinine kinase is therefore 4 divided by 3,302 minus 1 divided by 3,293, yielding about 0.09% of patients experiencing this adverse effect as a result of being given the drug. So it's not that bad. This implies that 100 divided by 0.09 is equal to 1,111 patients that would be needed to give, that you would have to give the drug to for one of them to get seriously harmed in this way. So number needed to harm can be compared with number needed to treat to evaluate the risks versus benefits of a given treatment. Sounds like information. I'm not going to say anything. All right. Attributable risk. The attributable risk is the additional incidence of a disease that is attributable to the risk factor in question. It is equal to the incidence of the disease in exposed persons minus the incidence of the disease in non-exposed persons. In the previous example of lung cancer in smokers, the attributable risk is 0.18 minus 0.01 or 0.17, 17%. In other words, of the 18% incidence of lung cancer among the smokers in the study, 17% is attributable to smoking alone. The other 1% is the background incidence of the disease. Its incidence among those not exposed to this particular risk factor. Attributable risk is sometimes called risk difference or cumulative incidence difference because it is the difference in the risk or cumulative incidences of the disease between the two groups of people. From this kind of data, we can calculate what proportion of the overall population's burden of a disease is attributable to the risk factor. This is called the population attributable risk, and it is equal to the attributable risk multiplied by the prevalence of the exposure. For example, if the risk of the lung cancer that is attributable to smoking, its attributable risk is 0.17, and the prevalence of the exposure to smoking, that is a proportion of the population who have smoked heavily, is zero point 0.4, then the population attributable risk is 0.17 times zero point 0.4 equaling 0.068. In other words, in the population as a whole, 7.2% of people have lung cancer that is attributable to smoking. Population attributable risk, therefore, gives us a prediction of how much of the overall burden of the disease in a population could theoretically be reduced if the risk factor were removed. In this case, if nobody in the population smoked, 6.8% of the total population would be spared from a lung cancer they would otherwise have developed. If the cohort of smokers and non smokers were representative of the overall population in the city in which they live, and if the city had a population of 100,000, then eliminating smoking would theoretically prevent 6.8% of these people, or 6,800 people, from getting lung cancer. This is the number prevented in the population, also known as the number of events prevented in a population, or NEPP. Odds ratio. Relative risk and attributable risk both require the use of cohort prospective studies as shown previously. As noted in chapters 5, cohort studies are generally expensive and time consuming and are therefore often impractical. A common alternative to a cohort study is therefore the case control retrospective study, in which people with the disease cases are compared with otherwise similar people without disease, so called controls. If the proportion of people who had been exposed to a possible risk factor is greater among the cases than the controls, then the risk factor is implicated as a cause of the disease. Because the proportion of people in a case control study who have the disease is determined by the researcher's choice and not by the actual proportion in the population, such studies cannot determine the incidence or prevalence of a disease, so they cannot determine the risk of contracting a disease. However, the strength of the association between the risk factor and the disease can still be evaluated with a case control study by examining the proportions of the people with and without the disease who had and had not been exposed to the odds who had not been exposed to the risk factor. This is done through the use of the odds ratio. Odds is the probability of an event occurring versus the probability of it not occurring. In other words, P divided by 1 minus P. For example, the probability of tossing a fair coin and getting heads is 0.5. The probability of not getting heads, 1 minus P, is also 0.5. So the odds of getting heads is 1. If you are as likely to get heads as not to get heads. Note that while probabilities can range only from 0 to 1, odds can range from 0 to infinity. The probability of tossing a coin and getting a head or a tail is essentially 1, and the probability of not getting a head or a tail is virtually 0. So the odds is 1 divided by 0, or infinity. You are infinitely more likely to get a head or a tail than not to get either. Let us re-examine the data in Table 8.1. Assuming now that this data was generated by a case control study in which history of prior exposure to the risk factor of heavy cigarette smoking was compared in 347 cases with lung cancer and 1,735 controls without lung cancer. So, of the 195 cases, 183 had been exposed to the risk factor, 12 had not been exposed. The probability that a case had been exposed to the risk factor is therefore 183 divided by 195, or 0.94. And the probability that the case had not been exposed is 12 divided by 195, or zero point zero 0.06. That is 1 minus p, obviously. The odds that the case had been exposed is therefore 0.94 divided by zero point zero 0.06, equaling 15.7. In other words, a person with lung cancer was 15.7 times as likely to have been a heavy smoker than to have not been a heavy smoker. Numbers have been rounded for simplicity, yeah. Hmm. Similarly, among the 1,887 controls, 825 people had been exposed to the risk factor and 1,062 had not been. The probability that a control had been exposed is therefore 825 divided by 1,887, equaling 0.45. The probability that a control had not been exposed is 1062 divided by 1887, equaling 0.56. So the odds that a control was exposed is 0.45 divided by zero point 0.56, equaling 0.81. A person without lung cancer was 0.81 times as likely to have been a heavy smoker than to have not been a heavy smoker. The odds ratio, or relative odds, is the ratio of these two odds. It is the ratio of the odds that the case had been exposed to the odds that a control had been exposed. So the odds ratio is equal to odds that a case had been exposed to the risk factor divided by odds that a control had been exposed to the risk factor. In this example, the odds ratio is therefore 15.7 divided by 0.81, equaling 19.4. This means that among the people in this case control study, a person with lung cancer was 19.4 times more likely to have been exposed to the risk factor of cigarette smoking than was a person without lung cancer. Hmm. An odds ratio of 1 indicates that a person with a disease is no more likely to have been exposed to the risk factor than is a person without the disease, suggesting that the risk factor is not related to the disease. An odds ratio of less than 1 indicates that a person with the disease is less likely to have been exposed to the risk factor, implying that the risk factor may actually be a protective factor against the disease. The odds ratio is similar to the relative risk. Both figures demonstrate the strength of the association between the risk factor and the disease, albeit in different ways. As a result of their similarities, the odds ratio is sometimes called estimated relative risk. It provides a reasonably good estimate of relative risk provided that the incidence of the disease is low, which is often true of chronic diseases, and that the cases and controls examined in the study are representative of people with and without the disease in the population. Preventative medicine. All kinds of measures of risks are invaluable for informing makers' decisions about how to allocate resources for the benefit of a population's overall health, especially with regard to choices regarding primary, secondary, or tertiary prevention. Primary prevention is pure prevention. It addresses the risk factors for disease before the disease has occurred. It may involve educating people about lifestyle changes, exercise, diet, avoiding tobacco use, reducing environmental factors such as exposure to pollutants or toxins, etc. Immunizations are prophylactic medications. It is sometimes believed to be the most cost effective form of healthcare as it reduces the actual incidence of disease. Secondary prevention involves identifying and treating people who are at high risk of developing a disease or who already have the disease to some degree. Focused screening programs are of this kind, for example, ultrasounds to check for abdominal aortic aneurysms in male smokers, chest CT scans to screen for lung cancer in heavy smokers. Tertiary prevention involves prevention of future problems, symptoms, complications, disability, death, or minimizing negative effects or restoring function in people who have established disease. Examples include screening patients with diabetes for nephropathy, neuropathy, and retinopathy, and treating them to prevent these complications, or performing angioplasties or coronary bypass surgery on patients with known coronary disease. Epidemiology and outbreaks of disease. Like epidemics, outbreaks are occurrences of a number of cases of a disease that are in excess of normal expectations. But unlike epidemics, outbreaks are limited to a particular geographic area. Epidemiological measures and methods contribute greatly to the understanding, identification, and treatment of outbreaks of disease. Many diseases that have the potential to cause outbreaks are reportable diseases, which physicians in the United States are required to report to their state health departments, which in turn report them to the CDC. The vast majority of these are infectious diseases such as anthrax, botulism, cholera, dengue fever, gonorrhea, hepatitis, HIV, Lyme disease, polio, rabies, syphilis, and so on. The only non infectious nationally reportable diseases are cancers, elevated blood lead levels, food and waterborne disease outbreaks, acute pesticide related illnesses, and silicosis. The National US 2012 Reportable Disease List, note that the individual states' lists may differ, is available at cdc.gov. Apart from reportable diseases, national and state agencies conduct ongoing surveillance of many other diseases and associated phenomena, including occupational diseases and injuries, over the counter medication use, illicit substance use, emergency room visits, and so on. Although some outbreaks are identified through analysis of surveillance data, they are quite commonly identified as a result of direct reports by clinicians. Initially, a cluster of cases may be reported. This is a group of apparently similar cases, close to each other geographically or chronologically, which may be suspected to be greater than expected. It may not be clear if this is actually in excess of normal expectations or even if the cases are actually of the same illness. So the actual existence of an outbreak may not always be clear initially. For reportable diseases, local, state, or national records provide a baseline from which to judge if an outbreak has occurred. But for other diseases, it may be hard to tell if a given cluster is greater than the background incidence of a disease. This is particularly true if local or national publicity brings symptoms of a disease to public attention, resulting in increased presentation by patients and increased testing and reporting by physicians. The use of new diagnostic tests or changes in the constitution of the population in question may also account for an apparent outbreak. Outbreak investigations. The first stage in modern outbreak investigation is to develop a case definition. In some situations, such as those of reportable diseases, the case definition is already well defined and is listed in the CDC document mentioned above. In other cases, it may be very broad and may be refined as the investigation progresses. It may be limited to a particular people, places, and times as well as to particular signs and symptoms. For example, all passengers and crew on a specific sailing of a specific cruise ship who developed vomiting and diarrhea, or all people with a specific lab finding. On the basis of this, cases are ascertained and further cases may be sought. For example, by interviewing everybody who was on that ship at that time, or by interviewing, examining, or testing their friends and family members, or people who were on previous sailings of that ship. With this idea, outbreak investigations then describe the times, places, and persons involved in order to rapidly identify the cause and transmission of the disease with the immediate goal of controlling and eliminating it. In the longer term, these investigations may reveal new etiologic agents and diseases, or identify known diseases in areas where they did not previously occur, leading to methods of preventing future outbreaks. By identifying who contracts the disease and when and where it occurs, the disease may be brought under control, even if the actual etiology of the disease is not understood. To describe the chronology of an outbreak, an epidemic curve or epicurve is created. This is actually a histogram showing the number of cases of the disease at each point in time, such as on a daily basis. Shorter periods may be chosen if the disease appears to have a very short incubation period. The overall shape of an epicurve gives clues as to the nature of the outbreak. A curve starting with a steep upslope which then gradually tails off, suggests that the cases were all exposed to the same cause at around the same time. This would be a common source epidemic, such as from eating contaminated food, and the time between exposure and the midline of the curve would correspond to the incubation period of the pathogen. If the curve has a narrow, sharp peak with a rapid decline, this suggests a common point source epidemic, such as a group of people at a banquet eating the same contaminated food at the same time. If the pathogen is known, for example, through lab tests, the known incubation period can be used to infer the, the likely time of exposure. If the peak of the curve is rather broad, this suggests a common continuous or persistent source epidemic in which the exposure lasted longer, um, such as were such as where a contaminated product remained in the food supply chain for some time. In an irregular curve suggests a common intermittent source epidemic in which people are exposed to the cause intermittently over a period of time. A curve with a series of progressively higher peaks suggests a propagated epidemic in which each group of people who contract the disease and then pass it on to another group. Places. A simple map of the cases of the disease, a spot map, can show the relationship of cases to each other and to potential infectious, toxic, and other environmental causes, whether natural or man made. The map may be of any scale as appropriate, a large geographical map, a local street map, or even a map of small areas such as an office building, a hospital, an aircraft cabin, or a ship. The classic example is the work of John Snow, an anesthesiologist in London, who marked the location of each case of cholera on a street map during an outbreak of a disease in 1854. He found that cases clustered around one particular public water source, the Broad Street pump, and also that two groups of people who lived near the pump were largely unaffected. They turned out to be brewery workers who drank alcohol rather than water, and what little water they drank came from a deep well at their workplace, and residents of a workhouse that had its own well. On the basis of this finding, the handle was removed from the Broad Street pump, and the epidemic was brought under control. Decades even before the use of microscope, let alone identification of the cholera bacterium and treatment with antibiotics. That's pretty cool. Persons. Basic information about the people affected by an outbreak provides very important clues: age, gender, race, comorbidities, medication use, travel history, vaccination history, use of alcohol or drugs, what they ate and when, employment, recreation, sexual activity, substance use or abuse, what other people they are habitually in contact with, such as children, patients, immigrants, and so on. Note that a person who has not been immunized against a particular disease may still be protected from it through the phenomenon of herd immunity, which is basically that if a sufficient number of other people are immunized, then it is unlikely that the unimmunized person will come into contact with someone with the disease, as there will be only a small reservoir of people who potentially could have the disease. Related to this is the concept of cocooning, which is basically immunizing people who are likely to come into contact with a susceptible person, so that the susceptible person is unlikely to be exposed to the pathogen. For example, it is commonly advised that adults get immunized against pertussis if they are likely to come into contact with newborns who are vulnerable until they have received at least some of their pertussis vaccine starting at the age of 2 months. A measure that helps describe who gets sick in an outbreak of a disease is the attack rate. This is the risk of contracting a disease, and it is actually the same as incidence, except that it is reported as the proportion of people who contract the disease in the specific outbreak in question. The attack rate is the ratio of the number of people contracting a particular disease to the total number of people at risk, expressed as a percentage. Um, so, for example, if you have 1,000 people that ate at a barbecue and 300 of these people became sick, the attack rate would be simply dividing 300 by 1,000 and multiplying that by 100 to get 30 people on 30% of an attack rate. Calculating attack rates for different groups of people can help the source of an epidemic to be deduced. For example, Table 8.2 shows the attack rates for each food or combination of foods eaten by different people at the barbecue. The putative source of the illness can be deduced by inspecting the table for maximum difference between any two attack rates. The largest difference between any two attack rates is 31%. This is the difference between the lowest rate, 9%, in those who ate the raw chicken and ribs only, and highest rate of 40% in those who ate chicken ribs and coleslaw. The implication is therefore that coleslaw is the source. Following the description of an outbreak in terms of times, places, and people involved, a number of actions may be taken simultaneously. Um, you can. Measures to control the outbreak may be instituted, such as engineering changes, exemplified by removal of the broad street pump handle, designing non reusable needles, etc., recalling of food or drug from the supply chain, environmental controls, regulatory changes, or encouraging behavioral changes. Communication with those affected or the public as a whole about the outbreak. There's also laboratory testing to identify the actual etiology if it is not known, or to identify undiagnosed cases. Further case findings, if others exposed to an apparent risk would benefit from diagnosis or treatment, for example, trying to locate people who may have been exposed to a person with TB on a long distance flight, or who may have received donated blood or organs from a person with communicable disease. Development of hypotheses about the cause of the outbreak and possibly planning further studies such as case control studies or cohort studies to test these hypotheses. Note that entirely atypical outbreaks, such as the appearance of unusual pathogens in unusual locations, might raise the question of deliberate human causes such as poisoning, sabotage, or bioterrorism.